detection I think about 10 years back, but now it's about 40-50%. Some improvement, but miles to go. We now have our own prostate cancer guidelines, which were published in the Indian Journal of Urology. So we have something to go by when it comes to the local burden of the disease. So this was just to give you a little bit of background. We'll jump on to case 1. This is a gentleman who stays in South Mumbai, supposedly, 63-year-old. He's got a history of hypertension, had TURP 4 years back, PSA of 7.1. Physical examination is normal. Prostate examination by ultrasound and upper tracts are okay. His PSA was 7.1, so his urologist advised antibiotics for 4 weeks and a repeat PSA thereafter. My question is for Dr. Srikanth. Do you think good idea, bad idea, should be done, should not be done?
He's a 63-year-old and asymptomatic, and urine routine is also normal. So there is a pretty good evidence that to show that prescribing antibiotics would not change the PSA, and even if it change, it may change in terms of like 0.5 to 1 range, and it does not alter the biopsy results.
Awesome. I think that's a great point. There is evidence to say that there is no benefit by giving these antibiotics, and in fact it may actually result in a higher chance of developing infections after a prostate biopsy because of the indigenous development of antibiotic resistance. So there is a recent antimicrobial use is one of the risk factors for developing infection. So definitely it should giving this this habit of giving antibiotics to patients who have a raised PSA but do not have any symptoms of UTI should definitely be stopped, and that's not something that is a beneficial thing. So anyway, we repeat the PSA after 4 weeks, 7.5, advised MRI prostate. Dr. Aparna, biparametric, multiparametric, what do you say now?
Okay, the key question here are 2, which you want the radiologist to answer.
Yes.
1, is there clinically significant cancer? 2, is the lesion targetable? In 9, evidence-based, in 9 cases out of 10, you are okay with the biparametric. You could pinpoint a lesion and that can be biopsied and etc. etc. In 1 out of 10 cases, like 10% cases, there is an issue, and that is typically evidence-based in one scenario, and that is a PIRADS 3 lesion in the peripheral zone. Anecdotally, me and many of my fellow radiologists also face a problem in the transitional zone lesions in a significantly enlarged prostate, because the transitional zone lesions are not those well demarcated T2 hypointense patch that we see. They are more irregular, so you sometimes don't know whether if it is a BPH nodule or it is some cancer that is hiding there. So these are the 2 cases where we face a problem and where a dynamic contrast enhanced MRI really helps a lot.
So is it okay, I'm sorry to interrupt you, but is it okay if we do a biparametric first and then decide to give the contrast if required?
The issue with that is a PIRADS or any RADS for that matter aims at having a uniform protocol throughout, whether it's here or in the Western world. Now to do that, there has to be a radiologist of significant experience right there at the console at every prostate MRI that is being done.
Correct.
How much of it, a lot of it is a learning curve as well.
Absolutely.
Which every one of us has gone through. So what radiologist is sitting at the console or the technologist to take that decision is what makes a difference, and is what is probably holding back the PIRADS committee from totally going on to a biparametric MRI.
Do you think it's going to happen in the future?
I think so.
Okay, so it's just a matter of time.
The way I see it, I feel if the PSA density is taken into consideration and then taken as a part of PIRADS, and then those borderline 3 or 4 lesions in the couple of scenarios that I told you, if that can be in some way amalgamated with the PIRADS, maybe we could move on to a bipar, and it would be a good thing to happen.
Extremely interesting. Is there any, it's MR spectroscopy is dead and been buried, or it's still okay? Yes.
Let's not even discuss, especially when the lady there is on her case.
A categorical answer, fantastic. I love that. 3 Tesla MRI, 1.5 Tesla MRI, 7 Tesla MRI. Keep on increasing the Teslas and.
No, we do it on 1.5 and
Okay.
we have absolutely no issues. What is important is that the protocol is standardized. You do a 3 Tesla MRI without a short field of vision T2, it's useless for me. It doesn't matter that it's a 3 Tesla. You give a proper 1.5 Tesla MRI with proper protocols followed and give me the necessary sequences in T2 and diffusion weighted images at least as a parametric. In most cases, I'm happy.
Excellent. So we don't need to go crazy after new technology.
No.
We are good enough with 1.5 for most of the things. So continuing with our case, this patient had a Pyrites 5 lesion diagnosed on an MRI, and there was some seminal vesicle involvement on the right side and a sub-centimeter external iliac lymph node. And then a biopsy was done, which revealed ISUP grade 4 adenocarcinoma prostate with about maximum 70%, 90% involvement, 7 of 12 cores positive with perineural invasion present. We'll just move on with the case. So this patient had a PSMA PET CT, and there was an uptake in the prostate with a doubtful external iliac lymph node on the left side, and there was no other evidence of any metastatic spread of the disease. The options obviously are either we go in for radiation therapy along with androgen deprivation therapy, or an aggressive surgeon like Dr. Srikanth would probably offer a radical prostatectomy and bilateral EPLND along with it. So I'll jump to Dr. Srikanth. What do you think that there would be an impact of a previous TURP? Would you offer this patient a radical prostatectomy at all, or would you just send him to Dr. Trinanjan or Dr. Abhilash?
No, I will offer him a radical prostatectomy.
Fantastic. That's the way to go.
Since
No bias.
Since he's like 63-year-old, who is
Okay.
quite young,
Yeah.
with no comorbidities except for hypertension.
That lymph node doesn't bother you?
He had a previous TURP, and it's a locally advanced, like seminal vesicles and a small lymph node. So he basically requires a multimodal treatment, like a hormone therapy in addition to a local therapy. So I would err on surgical side first, given his history of TURP and a high-risk disease.
So the fact that he's had a TURP, do you think that takes away from your ability to do a good surgery, in the sense that will it make things more complicated?
You have a paper published.
Yeah.
Yeah.
So absolutely no bias. It is from us. So
Yeah.
obviously I had nothing to do with this.
So definitely, like TURP will during the surgery it will cause increase in bladder neck. Bladder neck would be a wider. Then you may need to do a reconstruction, and you may need to keep the Foley longer. But the oncological and functional outcomes remains to be same.
So that's what we found in our series of patients, that we didn't have any difference in the complication rates, recovery of continence, or any oncological aspect when we did surgery in patients who had had previous TURP before. I'll jump to Dr. Amit. Now, Dr. Srikanth has insisted that he is going to do surgery, and the patient comes to you, and he says the patient is also very convinced that I'm going to go for surgery by Dr. Srikanth. So he asks you, sir, that should I take some hormone therapy before surgery? What do you say?
No, I think there is no role of neoadjuvant ADT, but in that case, if we are considering as a node positive and surgery is out of option, then definitely we want to add the abiraterone for 2 years with the current STAMPED data. So from that aspect, in this context, it should be a multimodal decision. It should not be. So I think a tumor board comprising of a uro-oncosurgeon, a radiation oncologist, and a medical, because this will be a controversial whether to offer them a surgery. Knowing a PSMA positive node, independent, I will prefer the patient to go for a RT with ADT with abiraterone rather going surgery when we know that there is a possibility, because the possibility of being node positive, pathologically node positive is more.
Here the patient is so impressed with Dr. Srikanth that he is absolutely not going to go for radiation. Now in this particular situation, do you want to add abiraterone like you would for radiation therapy? I'm going to come to you, Dr. Trinanjan. Just give me 1 minute.
So I think the data is not evolved for using the abiraterone in the adjuvant context, so I might not opt for abiraterone post-surgery So I will not give you abiraterone.
Absolutely. I think I agree that we have some evidence that given intense ADT, given the neoadjuvant fashion where you're talking about giving LHRH agonists along with abiraterone has been shown to have about a 20% chance that the patient will not have any residual disease on radical prostatectomy. And these patients who have a complete pathological response ultimately do better in terms of a 3-year biochemical recurrence-free survival. But definitely these are very, very preliminary data, and most of the guidelines do not recommend any form of neoadjuvant androgen deprivation therapy prior to surgery. So again, one thing that has been repeatedly stressed, we have a lot of patients who come for radical prostatectomy already having a shot of hormone therapy. It's really not doing them any good, probably harming them. Dr. Trinanjan, it's your turn now. So obviously, the patient goes to Dr. Amit. Dr. Amit says that, look, Dr. Shrikant is telling you surgery, but no, that's not the way to go. Go to Dr. Trinanjan, get radiation therapy.
Not get it, talk to them.
Okay. Right. So, sir, please.
This particular patient, there was a seminal vaginal invasion, lymph node has also lit up. What is the role of biopsy of the seminal vaginal and lymph node before deciding the treatment?
Dr. Shrikant, would you like to take that question?
So that would not change our management. It's either you counsel him to undergo a systemic therapy that he will require, like in the form of ADT, with a local treatment that could be either radiation or surgery. You explain the pros and cons and leave the decision to the patient.
Well, very.
If both are positive, and you know beforehand, would you like to operate still or you want to wait something else?
So the node positive, it's on the PSMA PET scan with a SUV of 2.5 only. So it's a very small node. So I will need to talk to our radiologist whether they will be able to do a biopsy and how that biopsy will come positive or not.
Right. So, yeah. So probably it may be, and even if it's positive, it would probably still be a good debate to whether to go in for surgery or go in for radiation. And okay, Dr. Nanjan. So he is coming to you. I don't think you can pull out all the guidelines and tell them, look, as per the guidelines, you should have radiation and androgen deprivation therapy. So let's jump on. I'm not asking you why he should have radiation. I'm asking you, okay, we got to give radiation. We don't know whether that lymph node is positive or no. It's suspicious, plus minus. So how would you decide your radiation field?
So just to answer your previous question, I would have loved that he doesn't have to do these 1, 2, 3 things. He meet all of them together and come to a decision.
Okay.
But that's maybe too hypothetical. But coming back to the question, with a suspicious node, see, this was a high risk to begin with. Now, whether it is high risk N plus or N minus. So anyhow, they're going to receive ADT in terms of being high risk. So what we do in node positive scenarios, that we wait for the next PSMA after say 1 or 2 shots of whatever way the hormone is given. Then see if the node has regressed in PSMA. If regress, treat as an elective dose to the node. If not regress, then boost that node with your whatever dose fractionation using for radiation in that case. So we would consider that node to be positive with a PSMA based response in
Let
ADT
me take
and
you one
PSMA.
step back. Suppose there was no lymph node on the PSMA PET CT. Would you still give radiation to the pelvic lymph nodes?
Yeah, an elective dose, 100%. This is high risk,
Okay.
beyond any doubt.
Okay. So it doesn't really change. The only decision to be made
No,
is
it
whether to give a boost
it
or
changes
no.
the radiation. Yeah, it
Yeah,
changes
whether
the
to give a
radiation
boost to the
volume. It changes what additional dose you want to give to that area.
Awesome.
If I
Dr.
could
Abhilash.
just-
Yeah.
If I could just add to that. So considering this is node negative, if I confirm with the radiologist and we go ahead for a biopsy or if it comes back negative, it is high risk and we will irradiate the prostate and the pelvic lymph nodes. And we have Indian data from the PAW party study. Considering the node is positive, biopsy proven as sir had raised, there is evidence from the UK as well, from the Royal Marsden's group, that even in N plus, again, this node is very small, SUV 2.5, we have evidence that radical radiotherapy with ADT is definitely beneficial. And of course, abiraterone can be added. That's a debate as well.
So great. I think this point about giving, looking at the response to the ADT and then deciding whether to boost the pelvic lymph node or no, and the data that you have expressed is really awesome. I think, to be honest, I didn't know about it, and thank you for letting us know. And if I was to go back to Dr. Trinanjan and ask, what is the radiation dose that you would usually use in this situation? And what's your comment on hypofractionation and ultra hypofractionation? You know, new terms for me, that relatively new, but awesome.
So it is more or less I guess the debate is settled in high risk across several studies. Hyperfractionation is more or less the norm. No point calling someone for 8 weeks with all the trouble. We have now 5 years data also from quite major trials. So hypofractionation in any format, I personally use a 3 gray per fraction. People can use it 2.8, 2.5. It
4
varies.
weeks, 6 weeks.
4 weeks.
4 weeks. You're done in 4 weeks. Saves money for the patient as well?
Not maybe really, but definitely saves in terms of the travel and all in a city like Mumbai. Definitely saves in that aspect. See, we cannot boil down that we have reduced the total duration and we'll be able to save the radiation money. See, we don't talk about, once we talk about robotic surgery for that. So why on radiation we'll talk about that we'll be able to save money by just reducing number of weeks. It requires expertise. It requires expertise from our side as well. It's not that 8 weeks has come down to 4 weeks, oh you're saving money for 4 weeks. It's not that. It requires more vigilance on a very serious note.
Absolutely.
Someone needs to start a hypofractionated protocol. For a radiation oncologist, it needs more time.
Absolutely.
You have to be around through see the images. You can't just let whatever may the bladder rectum.
What about ultra hypofractionation?
So ultra for high risk, in my personal capacity, yes, we are doing also ultra hypo, and I found it. We have Indian data with sitting here with Dr.
7
Vedant.
grays per sitting?
It's like 7.25 into 5.
And done in 5 days.
In 5 days, you can do alternate, you can do weekly, depending
And
on
if you
comfort.
stretch the limit, I heard Vedang once saying
1 day.
single,
day.
yeah, like, yeah. I don't
So
know what to call
Carlo
it,
Greco
but
from Portugal is very proponent of the single fractions. It requires definite an MR guidance, probably an MR LINAC in place. I don't know, frankly, as radiation oncologists, why we are so crazy about single shot for everything.
Vedang, throw the kitchen
so
sink
Dr.
at
Vedang,
throw the kitchen sink at the patient and run away. Right?